This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. This patient is a 75-year-old lady who has this dense, mature cataract. The nucleus is around grade 4 nucleus, and I'm going to demonstrate the direct vertical chop in this patient. The side puts are made, the anterior capsule is stained with trypan blue, and the chamber is pressurized with OVD. The globe is stabilized with my second instrument, and I'm going to make a posterior limbal groove, and a triplanar incision is going to be created using a 2.8mm bevel up keratome. So once the main incision is created, time to perform the anterior capsular rhexis. Since I'm expecting a denser nucleus, I want the rhexis to be slightly bigger. I want at least a 5mm rhexis in this eye. At the temp examination, the anterior capsule did not appear to be very tense, so I'm not expecting any difficulty in performing the rhexis. Let's see how things turn out. The capsule flap is raised, and with the Haldipurkar forceps, an appropriately sized rhexis is created. I don't usually do hydrodissection in these mature cataracts. I'm just trying to check the mobility of the nucleus. I want to ensure that the nucleus is mobile. Chamber is repressurized with OVD, and time to perform the phaco. The nucleus mobility is confirmed one time with my chopper. The phaco tip is introduced, and as you can see, this is an Kelman bent tip, which is the balance tip which I'm going to use with the Legion machine. And orientation of the tip when you're trying to remove the epinucleus can be bevel down as well, but definitely when we're doing sculpting, the bevel has to be facing up. This is what is my preferred practice, and that's what I would recommend. In this patient, because the nucleus is dense, my go-to technique is always to create a small central pit and then bury my phaco tip for the direct chop. So once I've reached about 30 to 40% depth, I bury the phaco tip into the substance of the nucleus. The long vertical chopper goes in and then comes towards the phaco tip. The lateral separation maneuvers are being done. At this point, it's very important not to push these fragments down during lateral separation. That is what most beginner surgeons would do, and this is the risk factor for inducing posterior capsular tear. So always lift up the nucleus with the right hand. The left hand goes down vertically, and then there's a lateral separation. So at no point we are going to induce a stress on the posterior capsule. The tip buries in, the right hand goes up a little bit, the left hand with the chopper comes down, and then there is lateral separation. This posterior leathery plate can be tricky. The trick here is to place the chopper as deep as possible, and we can see the last few attachments of the leathery plates can be taken care of. One of the fragment has just floated out of the bag because of the rhexis. So at this point, I'm going to change my settings to the quadrant removal mode and emulsify this piece, and I don't want to keep it in the antechamber floating around. Time to emulsify the next big chunk of the nuclear fragment. So now I'm left with a large heminucleus, which I would prefer to divide again into smaller quadrants. The phaco tip is buried into the substance of the nucleus. The lateral separation maneuvers are done to separate the fragments. The fragment is held with my phaco tip, and the apical attachments of the posterior plate are gently separated with the chopper. Tip is buried into the substance of the nucleus, the chopper goes down vertically, and then there is a lateral separation maneuver. For beginners, my recommendation would be to practice this maneuvers mentally before we do the case. We should be practicing these maneuvers 100 times in our head before we actually do a live case. See, the bottom line is when you're trying to do the chopping and lateral separation, the pressure should not be exerted towards the posterior capsule. The lateral separation maneuver has to be predominantly sideways, that is laterally. That is a fundamental aspect of lateral separation which the beginner surgeon should be mindful of. So as the cataract is dense, it's always wise to go and replenish some OVD before the last fragment is being emulsified. Now in this last fragment, I'm going to do the horizontal chop. The phaco tip is buried into the substance of the nucleus. The long syncytium goes in and hooks the equator. It is pulled towards the phaco tip, and the last few attachments of the posterior plate are gently separated laterally. The two fragments are then emulsified using continuous torsional energy, and that's it. It was not so difficult to deal with this dense brown mature cataract. There's hardly any cortex left, but nevertheless the small tiny fibers need to be taken care of. The bimanual I&A is used to do just that. The bag is inflated with OVD and the planned intraocular lens is placed into the bag. OVD both in front and behind the lens is irrigated out. Side ports are hydrated. That's it, the case is done. Okay, just to summarize, this was a demonstration of a vertical chop technique in a dense cataract. Is there a necessity to do a small trench, which I did in this case? Well, it's not necessary for most average grade nuclei, but in very dense cataract, it's important that we get a grip of the nucleus in the more deeper part. So if you get a grip in the more deeper part, there's lesser chance of inducing torque when you're doing a vertical chop and then lateral maneuvers. To have a deeper access, I prefer to do the small trench, which is about say 30 to 40% depth, and then the tip goes in and you have a good hold. And then when we use a sharp chopper to go down and then do the lateral separation maneuvers, there is a lesser risk of the nucleus undergoing torque. So that was it. Thank you for watching and hope you found this helpful.